Good day, my dear postgraduate students. In the last class of Glide the Slide, I had given you a slide with the history, which read as 5-year-old boy with diminution of vision and awkward gait. And this was a slide that was given. Anytime I would appreciate you people if you can notice the pattern of distribution of the cells. Diagnosis comes last. If not at all, fine. But pattern matters most. Now in this case, I am finding multiple circular structures, and in the middle there is a blood vessel, which means it is a papillary structure. Welcome to Glide the Slide. I hope you people appreciate the design on the screen. So this particular lesion can be present either in the brain or in the spinal cord. In this particular case, it is, say, an ovoid or a cylindrical lesion with a long axis parallel to the spine, thanks to adventures in neuropathology. Also, the picture taken from pathology outlines shows a tumor that is composed of rims of cells in a central papillary core. The intervening spaces are all the empty spaces into which the papillary projections are seen. The diagnosis for it is ependymoma. Definition: it is a neuroepithelial tumor with ependymal differentiation. And what is this ependymal differentiation? It is a layer of cell that covers the ventricles. If it is going to be the choroid plexus, there is slightly different cell. Anyway, the sites for it can be the supratentorium, posterior fossa, or the fourth ventricle, and the spinal. Based on the location and the molecular basis, example, supratentorial, it can be because of ZFTA or YAP1 fusions. In the spine, it can be MYC-N amplification. Here again, I am finding clusters or rather sheets of tumor cells which are having circular arrangement. And if I'm very careful, I'll be able to see a vessel within this. So this can be, for example, I'm able to see a papillary core again. So this can be a pseudo-rosette that is seen over here. Now, what is the clinical picture? The incidence is, it forms about 2% of the CNS tumors and 6.9%, nearly 7% of glial tumors. And look at this, thanks to Neuropath Web, it is a cross-section of the brain, and I'm able to see the ventricle, which is almost completely filled with the tumor. The brain parenchyma is relatively or grossly unaffected. There is a bimodal population affected by it. Infants less than 1 year of age, or it can extend up to 5 to 15 years, and young adults. This is one. The second one can be the fourth decade, and this particularly occurs in the spinal. And when it is going to be with a history of 1 year infant, we should be careful because there are many blastemal tumors which can be there, and all will be having a history of less than 3 years or 2 years. Male-female incidence is equal. Pathophysiology. It is occurring in a progressive cell population. It is not a particular cell. In the sense, there are undifferentiated neural stem cells and then radial glia cells and the well-differentiated ependymal cells. There are three cells. That is why in the first slide, I am able to see almost a very well-differentiated tumor, whereas in the previous slide, it is composed of small undifferentiated cells. The etiology for this is unknown, but the clinical history can be pain, sensory loss, or sometimes a hydrocephalic because of the obstruction. Seizures. For any CNS tumor, this should be one of the history that should be in mind. So, hierarchical, progressive cell population. This word you should remember. That is what I am seeing over here. Now, let me describe this particular tumor. It is cellular, very obvious, numerous cells, well circumscribed, not capsulated, but circumscribed. It may infiltrate into the surrounding brain parenchyma. It is monomorphic. All are small blastemal cells over here. And there can be speckled chromatin that can be present. Pseudo rosettes, as in this case, or true rosettes may be seen. Areas of necrosis and myxoid degeneration. That was seen in the first slide. And there can be calcification or neuronal differentiation. There are three grades of it which have been given. Grade 1, grade 2, and grade 3. Grade 1 is basically, it arises from the subependymal cells. I shall be showing you. So it is called a subependymal. Whereas WHO grade 2 and 3 come under the group of ependymoma. The differential diagnosis can be. Incidentally, this is the tumor. Look at this one. It is linear, it is ovoid, arising from the spinal cord. Thanks to adventures in neuropathology for the spectacular pictures of this. The differential diagnosis can be an infiltrating glioma, astroblastoma, medulloblastoma. These are all having a cellular morphology that is similar to the blastemal cells or undifferentiated cells. Schwannoma and meningioma, on the contrary, are because of the location. Look at this one. This can mimic a schwannoma or even a meningioma in the spinal cord. GFAP is negative in meningioma. SOX10 is positive in a case of schwannoma. Now, a fantastic picture again. I am able to see this elongated cells and there is a core and the nucleus is all tending to be away from the center. So this is the kind of basement membrane that's formed and usually the nucleus should be adjoining the basement membrane, but it is far away. So this is called as reverse polarity. It can be positive for S100, GFAP or Vimentin. Thanks to web pathology for this picture. The tumor is well differentiated. Here again, neuropathology web. You are having a core, these are all columnar cells, the nucleus is away from it and it is called as reverse polarity. This is a normal structure that we are seeing. So there is a blood vessel, there is a basement membrane, there are the cells and the nucleus is away from it. These are the normal subependymal cells that are seen in the body. We shall glide to the next slide. The question for the day is, I would like you people to kindly identify the structure and mention its relevance in pathology and also explain what is reverse polarity. See you in the next class. Thank you.